physiology of female reproduction. Just like the male reproductive system, it's under both hormonal control and nervous system regulation. I forgot to mute the volume. Sorry. All right, development of the reproductive organs, normal function. It's dependent on actually quite a number of hormones in the body. As you can imagine, because the female body carries a baby, it is a little bit more complex. Okay, so puberty. Between the ages of 11 and 16, the females experience their first menses, which is called menarche. The vagina, the uterus, the uterine tubes, the external genitalia all begin to enlarge. Fat is deposited around the breasts and the hips, which give us our female shape. Yes, we are supposed to look like an hourglass, not like a toothpick. The whole reason that we have padding around our hips is because it's supposed to pad the baby when we get pregnant. And of course, the breast tissue is so that we can feed the baby. The ducts of the breast develop. So kind of equivalent to the seminiferous tubule in the, hang on one second. Sorry, got a weird text. Anyway, just like the seminiferous tubule in the males that's kind of solid and not functional until they hit puberty, it's the same with the female breast tissue. We do have ducts that make breast milk when we've had a child, but before puberty, they aren't functional. They don't work. Pubic and axillary hair also show up. Don't forget axillary means armpit. And our voice does change. It is to a lesser extent than what you see in males. We don't have the huge hypertrophy that gives us an Adam's apple that you see in males, but our voice does drop slightly. Also, during this time frame is when the development of our sex drive also comes into play. So, the menstrual cycle. This is cyclic changes that occur in sexually mature non-pregnant females. They culminate in menses. In menses. Although this is the classical definition now, nowadays, it also includes changes in the hormone secretion levels, in the ovary, and in the uterus. There's a period of hemorrhage in which the uterine functional epithelium, that inner layer that we talked about, is sloughed off and expelled from the uterus. Menstruation is actually the discharge of blood and the elements of the uterine mucus lining. So we've got the pituitary gland coming into play, what's happening in the ovary, and what's happening in the lining of the uterus. So technically, our first day of menstruation is that first day that we start to bleed. Our actual lining in our uterus is the thickest it's going to get if we don't get pregnant and we start sloughing it off. When that happens, you can kind of see there's a bit of a drop in estrogen, there's a bit of a drop in progesterone, and we start developing our new follicle that will be the one that will be ready to get pregnant with the next month. So it goes from being a primary follicle into a secondary follicle until it becomes a mature Graafian follicle. That's about day 14-ish. And about day 14, there is a huge surge in estrogen. There's a surge in luteinizing hormone, that's what LH is, and a surge in follicle stimulating hormone. Now remember, follicles in this case, in females' case, are going to be the oocytes, and it's stimulating them to be released. So about day 14, 15 is when ovulation happens. Remember, this is an average. Different women have different cycles. And you can see that estrogen drops pretty quick, but then progesterone actually starts to come up. That progesterone level starts to come up as that corpus luteum becomes mature and starts producing, uh, well, producing the progesterone and estrogen. You'll notice that here, even this estrogen is still higher than what we started out with between days, I'd say days 5 to about 10. Now, LH and FSH go down pretty quick right after. They don't stay high because pretty much the reason for their existence is to get that oocyte released. Now, notice that throughout all of this, once we're done with menstruation, we are getting our uterine lining very, very thick here. Basically, again, that perfect amount of thickness so that if you get pregnant, it's perfect for an egg to implant into, well, not an egg, but a baby to implant into a fetus. So all of these events are happening at the same time. And to be honest, when I first started teaching this class, all of these had their own cycles. So there was the ovarian cycle and the pituitary gland cycle and the uterine wall cycle. But now they've just kind of compacted it into one set of steps. So the menstrual cycle. The first day of the menstrual cycle is considered the first day that you start menstruating. It lasts 4 to 5 days, again on average, other people longer, other people shorter, just kind of depends. Halfway through that 28-day cycle, day 14 is going to be when you see ovulation. It's typically time between ovulation and the next menses is going to be 14 days. If you're averaging a 28-day cycle, this is dead center in the middle. So we've got 4 phases in the menstrual cycle. Sorry. The first phase is going to be the follicular phase. Between the end of menses and and ovulation, not the beginning of ovulation, but so here's the end of the menstrual cycle here. Here's ovulation, okay? So you've got this follicular phase where you've got that rapid development of the follicle into this mature Graafian follicle that can be ovulated. The second stage is the proliferative stage or phase. It's basically when that uterine mucosa starts growing to get to its appropriate thickness, okay? The luteal phase, the third phase, is pretty much after ovulation, so about here, until the next menses starts, which is right here, because that's that first day of bleeding that you can see down here, okay? Now, the secretory phase, that's actually the menstruation itself, so it's here. That bleeding phase until you stop bleeding. So it's menstruation and secretion by the uterine glands themselves. So those are number 1, the 4 phases of the menstrual cycle. Now, sexual behavior and the female sex act. Sex drive, it depends on hormones that come from things like the adrenal gland and other tissues that convert steroids into androgens. Androgens are hormones that may affect the brain cells, especially those of the hypothalamus that influence sexual behavior. Psychological factors also play a large role in sexual drive. Again, it's not just about the physical. For humans especially, it's also about the mental. So, the neuronal pathways involved in controlling the sexual responses are the same as in the male. You've got sensory receptors in the genitals that send action potentials to the sacral region of the spinal cord. In the spinal cord, you've got the spinal cord that governs sexual responses that are integrated, but it'll still go through the ascending pathway up to the brain. It'll travel through the descending pathway back to the sacrum, and thus cerebral influences modulate the sacral reflexes. Action potentials are conducted from the spinal cord to the reproductive organs by both the parasympathetic nervous system and the sympathetic nervous system, and to our skeletal muscles by the somatic nerve fibers. This is the same as in males as far as who's controlling what. It's not just one thing that's controlling everything. So, the parasympathetic nervous system. Sexual excitement will cause the erectile tissue of the clitoris and around the vaginal opening to become engorged with blood. The nipples will become erect. The mucus glands of the vestibule will start to secrete small amounts of mucus, with a large amount actually coming from the mucus glands that are lining that vaginal wall. Okay? They're not well developed glands, but they still contribute to the lubrication of the vaginal canal. These secretions will provide, as I just said, lubrication. They'll ease access and movement of the penis during intercourse. When it comes down to it, the more lubrication you have, the easier it is to actually have intercourse. One of the reasons that most of the time you can tell if a person's been sexually assaulted is because there is no lubrication. Tactile stimulation of the female genitals can also aid in stimulation. Psychological stimuli can trigger plus psychological stimuli can trigger an orgasm, which is basically contraction of both the vaginal and uterine and perineal muscles. They contract rhythmically, and the muscle tension of the body increases throughout. After sex, there's a period of resolution. It's characterized by an overall sense of satisfaction and relaxation. Unlike males who can have one orgasm and then they're done for sometimes hours or even longer, females can have multiple orgasms. They can have them back to back to back. But realize that an organism isn't required for fertilization. It actually can help, though. So this contraction that we're talking about, if this is the cervix and this is the back of the vaginal canal, there's kind of like a little area that the sperm pools in. When you have an orgasm, that cervix actually dips down and comes back up and dips down and comes back up into that pool of semen, basically not ensuring that you get pregnant, but it makes it more likely that you'll get pregnant. That's one of the reasons why when people are trying to do artificial insemination at home, they say to try and get the female to have an orgasm, because it helps to try and get that semen into the right place so that it can travel where it needs to travel. But again, it isn't required for fertilization. There are plenty of women who don't actually orgasm and they still get pregnant. So, fertility and pregnancy. The sperm cells are ejaculated into the vaginal canal down here, okay? But they actually do have to travel quite a bit of distance. Wait a minute, I need the eraser first. So they're down here. They have to travel through the cervical canal, through the uterus, and actually get up here into the fallopian tube, because they fertilize that secondary oocyte up here, almost at the very end of that fallopian tube, okay? So sperm cells ejaculated into the vagina during intercourse are transported through the cervix, the body of the uterus, the uterine tubes, and to the ampulla, which is kind of this widening that you see right here. Okay. You need it to fertilize way up there. Now, the forces that are responsible for the movement of that fertilized egg to get it back into the actual cavity of the uterus, rewind. I got ahead of myself again. I'm sorry. So the movement of the sperm, what's responsible for that? Well, one is the swimming ability of the sperm. Remember, we talked about the acrosome and how it kind of makes a little tunnel. It burrows a little tunnel to get to that area. That's one. possibly the muscular contractions of the uterus. Like I said, if you have an orgasm and you're dipping into that pool, it kind of helps it get to where it needs to go. And the uterine tubes themselves may actually help with not only contraction, but maybe even those ciliated cells. The contraction is stimulated by oxytocin from the anterior pituitary. And remember that the semen has those prostaglandins that cause smooth muscle contraction as well. So all of these things may help to get it to where it needs to go up here at the ampulla. So the sperm undergoes something called capacitation. Okay, capacitation. Basically, it's removal of proteins and the modification of the glycoproteins of the sperm cell membranes. Remember the helmet, the acrosome, the enzyme helmet that I talked about? Basically, it's almost like you have to rub off a little bit of the top to get the enzyme activated, to get to the enzyme that's inside. It would be like somebody making a pencil and then putting a coating on top of that eraser. In order to get the eraser to work, you kind of have to rub on it initially to get that kind of outer layer off so that you can get to the actual part that works. So these acrosomal enzymes, the ones in that little helmet that I drew earlier, they allow for penetration of the cervical mucus plus the cumulus mass and the zona pellucida to get to that oocyte plasma membrane. If I'm going to combine the half a nucleus from the oocyte and the half a nucleus from the sperm, they actually have to fuse together. Now, this is something that's kind of interesting. This oocyte will last for 24 hours. Sperm can last up to 6 days. Last. I think I forgot to put the T on there. For fertilization to be successful, intercourse either has to occur 5 days before ovulation or 1 day after ovulation. The timing has to be right for this to happen. Now, amazingly enough, a lot of people get pregnant, so it's not completely impossible. But if you're deliberately trying not to get pregnant, you have to really be aware of how many days are between times that you have intercourse, because if sperm can last for 5 days before, so you have sex 4 days before you ovulate, there could still be some little swimmers in there that can possibly fertilize that egg. So once you do have the fertilization has happened, so fertilization has happened right here, that will actually turn into a cell, a full cell with a full set of genetics to it. So over the next few days, there are sequential divisions that occur as the cell passes through the uterine tube. Okay? Now I want you to notice something about these divisions. I go from the one cell that I started with to 2, 2 to 4, 4 to however many. But notice that the size of this has not changed. It is still the exact same size. It's almost like taking a pie and cutting it into slices. It's not like because I've got 10 slices, that pie has gotten bigger. It's just taking the volume that's there and making it smaller. One of the primary reasons that we have to do this is a very, very small tube. If you look at that uterine tube is narrow as all get out, right? I mean, look at it. If I start growing this mass while it's still in the tube, it's going to act like a cork and it's going to get stuck. So even though I'm creating more cells, I'm not getting bigger physically. So by days 7 and 8 after ovulation, days 21 and 22 of the menstrual cycle, the endometrium, that lining of our uterus, is completely prepared for implantation. Estrogen and progesterone, EMP in this sentence here, are estrogen and progesterone, have caused it to reach its maximum thickness as well as secretory activity, and the embryo begins to implant. So here's day 6. Do you see how I've kind of got this hollowed out ball of cells? The thing you have to remember about these cells. I don't have an umbilical cord yet. So literally, as this little bundle of cells, I have to burrow into the lining of the uterus. And by burrowing in, basically, I'm soaking myself in the nutrients that the uterus is releasing, giving me the nutrients I need to continue to divide and to make more cells. So, the outer layer of this embryo is called a trophoblast, which you can see in green here. There's the trophoblast, okay? It secretes a proteolytic enzyme. Proteolytic. Lysis means to break, protein. It breaks down the protein so that it can burrow and digest the cells of the thickened endometrium of that lining, allowing it to burrow into place. It has to implant. Now, this is another reason why, if it's already in here, I can't fertilize it and become pregnant, because at that point, do you see how many times I'm dividing before I get to this thing here? This has enough cells and can make enough enzyme to burrow into the lining of the uterus. And that's on day, 6, I think? And implantation happens day 7, 8. If I'm on day 1 or day 2 and I fertilize in the actual chamber of the uterus, I don't have enough cells to make enough enzyme to burrow in the way I need to. By the same token, if I'm in, trouble and my ciliated cells aren't helping me to move, and I end up, actually enlarging in size inside of this fallopian tube, like I said before, you get stuck like a cork. That's an ectopic pregnancy. That's dangerous, because if it grows big enough and it actually ruptures that fallopian tube, you can hemorrhage to death. So, yeah. So, here's my trophoblast. Okay? The trophoblast secretes something called human chorionic gonadotropin. HCG actually is what causes that corpus luteum to remain functional. If your body, if the baby's body starts making HCG, then pretty much the corpus luteum knows, oh, it is pregnant. I have to keep making estrogen and progesterone so the lining of the uterus stays in place. So, with the corpus luteum basically remaining functional, progesterone and estrogen levels continue to rise. They continue to get higher. They peak around 8 or 9 weeks after fertilization, and they decline by week 16. Then they will remain relatively constant through the rest of the pregnancy, and you'll see why that is in just a minute. It's actually the basis for some pregnancy tests. When you pee on that stick, most of the time they're looking for HCG. That's what they're looking for to be in your bloodstream, because it pretty much guarantees there's a baby making it, basically saying you can't slough off the lining of your uterus. So initially, the corpus luteum is responsible for progesterone and estrogen secretion. But after the first 3 months, the placenta of the baby can take over. Remember, this little ball of cells is microscopic still. It's teeny, teeny, tiny. It can't produce enough estrogen and progesterone during that first 3 months to actually maintain enough of that hormone level to keep the uterine lining intact. So in that first trimester, the ovary is what's primarily responsible for giving you your estrogen and progesterone. And you can see that in that first trimester, HCG production is like huge. Look at how big that arrow is. So HCG is way up here. That's keeping the estrogen and progesterone being produced by that corpus luteum. Now, by the second trimester here, that baby has gotten big enough that the placenta in the baby now can make its own estrogen and progesterone. It still is making HCG, but look at how little HCG it is compared to that first block, right? But also look at, as that HCG level goes down, that corpus luteum is also not making near as much estrogen and progesterone. By the third trimester here, there is no more progesterone and estrogen coming from the ovary and the corpus luteum. Why? Because this placenta is big enough that it can just take over. It's big enough that I can maintain the uterus all by myself. So the lining of the uterus stays intact because the placenta is still making progesterone and estrogen, signaling to the body, don't get rid of the lining yet. Okay, so menopause. Women of the ages 40 to 50. Cycles will start to become less regular. Ovulation often doesn't occur. An eventual stop of the cycle happens. You stop having your menstrual cycle. Menopause, if you're actually talking about the definition of that word, that's when your menstrual cycle stops, when it's done, when you've had your last one. Premenopausal or female climacteric is what we call basically the time frame when you start having irregular periods until they stop. So that premenopausal time frame is when your period is not, happening every 28 days. It's associated actually with changes in the ovaries. The number of follicles is small. The follicles and the ovaries actually will start to become less sensitive to both luteinizing hormone and follicle stimulating hormone, which means that instead of getting the signal, okay, it's time to release an egg, it's like it just doesn't respond to it. Now, if you think about it, men can have children, they can be 102 years old and they can still father children. Women, however, don't. We stop usually in our 50s and our 60s. Why? Think about the physical toll on a human body it takes to have a baby. Now imagine being 50 or 60 years old and having that physical toll happening. It's terrible. I mean, honestly, your body, again, I've said this in other classes. I don't know that I've said it in this one. Really and truly, the human body probably wasn't designed to live as old as we do. It's probably, 40, 50 years old. Back in the days when we were living in caves, we were dead because our body wasn't made to survive that long. We've come up with, advances in science. We've got antibiotics now. We've got the ability to, do prosthetics. We've got the ability to replace vitamins and hormones and things that can go wrong. But ultimately, being that old and having children would just be, harsh on the human body, on a female human body. So we don't get pregnant past that point. There have been 2 cases that have been documented. One woman was, I think, in her 60s, and then I'd say probably within the last year, there was another one, and the woman was like in her 70s. And I'll be honest, that's ridiculous. And it didn't happen naturally. Both of these women had IVF treatments. The woman who was in her 60s lied and said that she was in her 40s and it was her last chance to get pregnant, blah, blah, blah. But the woman in her 70s, I believe it was actually the medical team that wanted to see if they could do it. And she was in her 70s, and I think her husband was in her 80s. The thing that makes me sad, though, if our average lifespan currently is in your 80s, those babies will not actually grow up with their parents. Their parents will die before they're grown. And that makes me sad. But that's my own personal thing that has nothing to do with the class. Okay, so the side effects of menopause. Well, vasomotor symptoms include hot flashes and palpitations to your heart. So vasomotor, your blood vessels, how is your cardiovascular system handling this? Honestly, for women going through menopause, they tend to have hot flashes where, they're just burning up. They feel like it's 100 degrees in the room when it isn't. Some psychological symptoms, you can see increased depression, you can see anxiety, irritability, mood swings, even a lack of concentration like a fuzzy brain. Um, Atropic symptoms are going to be things like vaginal dryness and an urgency to urinate. The pelvic floor isn't as strong as it was before, so you're not able to hold your urine as well as you used to. This is especially true for women who actually have children. Um, it weakens the pelvic floor. Treatment, well, you can do estrogen replacement, but before you decide to do that, you kind of need to weigh both sides. The benefits of doing estrogen replacement, well, it can prevent osteoporosis and possibly prevent colorectal cancer. There's some evidence suggesting that, but it's not really well backed up. But here are the risks. One, it prolongs the effects of menopause. So you're having mood swings and you're having hot flashes for a longer period of time than if you would have just, given up the ghost. Two, it increases your risk of breast cancer, of ovarian cancer, of uterine cancer. It also increases the risk of heart disease, and it may, these are the things that we're not sure about, it may increase the risk of heart attacks, strokes, and blood clots. I know many women who have done estrogen replacement therapy, and that's fine. But if that's what you're choosing to do, you kind of need to, like I said, weigh your options. The other treatment that you can seek is psychological counseling. There's nothing wrong with going to counseling, especially if it helps. So, the effects of aging on the reproductive system. Last slide of the semester. Yes. Okay, so changes in males. There's a decrease in the size and the weight of the testes, as well as the number of Leydig cells. Sperm production actually does go down as well. But remember, if I've got 2 billion sperm, I can cut that by half and have 1 billion and still have plenty of sperm to fertilize an egg. Okay? Sexual activity normally also decreases, and normally it has to do with basically an impedance risk increase with blood flow. Thinning of the seminiferous tubule walls happens. So instead of having, strong seminiferous tubules in the testes, they're kind of thin. The prostate gland will also enlarge. Now remember, the prostate gland is like having an apple with a straw in it. Now imagine that apple growing. What happens to the straw? It gets squished. That's actually a really common issue. Now, the impedance risk increasing. This is a physical reason for erectile dysfunction. Viagra was actually discovered quite by accident. It was a blood pressure medication originally, and they were doing beta tests in nursing homes. And men who hadn't been able to get an erection for years and years and years were all of a sudden getting erections. Now, as a blood pressure medication, it was terrible. It was like toilet bad. It was awful. But it had this kind of interesting side effect. So rather than Pfizer losing all of the money that it put into the research for this blood pressure medication, it just remarketed it. And I mean, Pfizer has made probably billions off of that one medication because of what it does. In females, the most significant change is going to be menopause, which we just finished talking about. The uterus does decrease in size, the vaginal wall does thin. And as we get older, there's an increased risk of breast cancer, of uterine cancer, and ovarian cancer, which normally is one of the reasons why older women tend to get hysterectomies, because either uterine or ovarian cancer kind of crops up, and it's easier just to get a hysterectomy. But again, it kind of depends on, I guess, your doctor, and it also depends on whether or not you develop those cancers. If you don't, then And that is the end of chapter 28. Yay!